Okay, so medications. What medications do we give? So our loop diuretics. Ashley, what's a loop diuretic? Do you know what type of that? What's a diuretic you give a lot?
Is it furosemide?
Lasix. Yep, that's your loop diuretic is Lasix. What happens if you give Lasix too fast? Anybody know? That's just a little trivia here.
Is it ringing in their ears?
Right, and even deafness. So you really have to watch when you push Lasix. So yeah, good, Carrie, good. Thiazide. These are given in combination with your loop diuretics, such as the hydrochlorothiazide. Okay. Potassium sparing. Katie, what's a potassium sparing pill that you have probably given?
Is it spironolactone?
Adactone. Spironolactone. Yeah, good. Beta blockers. Michelle, what type of beta blockers? What pills are those?
Are those the ones that end in pril?
Yep. So atenolol, metoprolol. Yep. So those improve the signs and symptoms of left-sided heart failure. ACE inhibitors. Jessica, what are we looking at there?
Like lisinopril.
Vasotec. Yep. Good. Positive inotropes. Sydney, do you know what a positive inotrope is? Might be a hard one. We'll really get into these in the shock lecture, but we do use these. Any idea?
Maybe the positive inotropes.
Or what? What are they? Do you know?
Oh, sorry, I'm not really sure.
Okay. Anybody have a guess?
Is it like dopamine or dobutamine?
Good. You got it. Dopamine, dobutamine. Yes. So the positive inotropes increase a cardiac contractility. So like I said, when we get into shock, we'll get into those a little bit more. Okay? And cardiac glycosides. Summer, what do you think those would be? They act directly on the cardiac muscle.
Digoxin.
Yep, your digoxin digitalis. Yep. Good. So that is our main medications you're going to see for heart failure. You may see other ones, but those are the main ones we're working on. Okay.
Question real quick.
Sure.
Did we say that the prils were beta blockers?
Did I have that wrong?
Because isn't that like metoprolol is the beta
Right.
blocker?
Yes.
Okay.
I'm sorry, we was wrong on that. Yeah, the ACE inhibitors is a pril. Yeah, when she said that, I was looking at the wrong paper. You're right, Garrett. You good catch. Okay, so that is about the heart failure. What we use to monitor heart failure is hemodynamic monitoring. Those of you that have got to float to ICU, you have seen a lot of these. So this is used to assess the cardiovascular function in critically ill. Our goals are to evaluate the cardiac and circulatory function. Direct means obtained straight from the monitoring devices. Indirect is calculation. Don't worry about knowing the difference in those two, okay? So one, you will see in ICU. Some of you have even got to help take these out. Doctor, of course, puts them in, or nurse practitioner, I'm sure, can now. Inserted directly into the radial or brachial artery. I've only seen them in the radial. Has anybody seen them in the other ones? I've only seen them in the radial.
I saw one in the femoral this last week.
Okay, good. So you might see them somewhere else. Majority of the time, it's going to be the radial.
Yesterday we had a patient with the, it was in the brachial.
Okay, well, there you go. See? A good thing I asked then. You just never know where you're going to see them. So anyway, what does it do? Continuously monitors that blood pressure. You don't have to worry about having that cuff, about setting a time for the pressure to take. So continuously going to monitor that. They can draw ABGs off of it, other blood draws. They might give meds through it, very rare. Did you guys that was in there give any meds through it? Not usually.
No, but we got her glucose off of it.
Okay, yeah, so any blood draws you can get off of it. So they're going to check the ABGs, and it always monitors their blood pressure. So it's a good way to keep a very accurate count on that.
What kind of patient would have one of those?
What do you want?
Like examples, like what kind of?
Okay, girl, like Zoanne, what did your patient have that she had to have one?
My patient was on 3 vasopressors. She was intubated. She had a lot going on at the time. They also had her sedated and paralyzed.
Mm-hmm.
So they were constantly getting her ABGs. So, and they had her in prone position.
Oh, wow, okay.
So it was a mess.
I'm sure. So their summer, it's just a good way to be able to get what they need without having to go in another maybe per se, if you want to look at it that way. But, that saves respiratory having to come in and do so many ABGs when they can just draw it from there. Does that help?
Yeah, I see them a lot on intubated patients in the ICU. That's all I've ever really seen them.
Good.
That's what I was thinking. So mostly like ICU type of status.
Yes, you will not see that on the floor because they
Right.
will have to be monitored. So you will not see it on the med surg floors or even a step down. Okay, good talk. This next one, I talked to some of the ICU charge yesterday. You will not rarely, she said she's maybe seen one in a year. Just know if you hear, and it could be on your boards, I mean, it's slim chance, but pulmonary artery pressure monitoring. So I will probably not be asking you anything about this, but just know they're going to evaluate worsening heart failure. It's going to let them know. Here's a picture of how it goes into the lungs. You may see it like in CVICU, but it's very rare that you will see this being used. I don't. Have any of you seen it? I myself has not even seen this, but it is in your book. We do have to talk about it. So, okay, so it's mostly left side heart failure that they're checking on that. Now this one, you will probably should know your range on that. Central venous pressure. So where it's measuring the blood volume and the venous return. Reflecting the right heart filling pressure. So any patient receiving vasopressors requires central venous line for drug administration. Okay, a normal range, because they do range them, is 2 to 8. Okay, if it's below 2, it could be a sign of hypovolemic shock. If it's above 8, it could be fluid overload, vasoconstriction, or cardiac tamponade. Okay, so normal range is 2 to 8 on your CVP lines. And there's a picture that explains how it goes through the subclavian vein. Okay. Have any of you worked with those that's been in the ICU? Okay, all right. So what's your nursing care if a patient has these lines? Of course, prevention, we're going to watch for risk of hemorrhage, right? What if they pull that art line out? Woo, So we really have to watch them for risk of hemorrhage. They'll be on a monitor. They usually have alarms set. They can get the thrombus, either air or blood clots. They can get an infection, right? Dressing changes on those. Pulmonary infarction with your pulmonary wedge pressure. They could go into a dysrhythmia when they insert and remove them. So really have to be watched. Even a structural trauma with removal, if they just don't get it done right. So this is your nursing care of the patient with the lines. Yeah, that's all I have on that. Okay, some more disorders you're going to see. Here is our rheumatic heart disease. So the valve leaflets become rigid and deformed. The choroid tendinae fibrose and shorten. Our signs and symptoms, they're going to have fevers. They're going to have painful tender joints. How do you think we're going to treat these? Who haven't I picked on here? Carson, how do you think we'll treat these people with the rheumatic heart disease? Any idea? Anybody else?
You're gonna try
Should we
to
be doing a valve replacement?
It might get to that. Before that, what were we going to do? Somebody else was starting to talk.
we're gonna try to reduce the afterload on the heart, so that we don't have that pressure, so the valve would leak less.
Okay, so what we're going to do is antibiotics, right? We're going to treat that fever, aspirin maybe, corticosteroids, right? Because their joints are getting painful. So we're going to do all those before they get to that point, right, Perry? We
Okay.
don't want them getting to that point, and whoever else said the valve, replace the valve. We don't want to have to get to that point. Good. Cardiac tamponade. So this is a medical emergency. Results from pericardial infusion, trauma, cardiac rupture, or hemorrhage. We'll talk next week in our cardiac surgery lab that there have been times they had to go into while the patient was in the room before they could get them back to OR and open them up right in the room because of cardiac tamponade. So it's very emergency. So what's our signs? They'll have elevated CVP. And what was our CVP level, Nikki? She's not listening.
Nikki texted me. She said 2 to 8.
Okay. She's right. So it's going to be above 8. They're going to have JVD with that. They're going to have muffled heart sounds. They would probably be cyanotic. Okay. So our main treatment, we got to get rid of that pressure and that cardiac compression. So we're going to drain the fluids. Pericardiocentesis, right? If they're hypertensive, they're going to need IV, inotropic agents. But very much medical emergency. And you can see how it's just like whited out in there. So I would probably read up on your cardiac tamponade in your book. Because it's a very highly thing that you will probably be tested on in boards. Very known thing to know. So. Okay. This is endocarditis. Pretty, isn't it? Inflammation of endocardium can involve any portion of the endothelial lining of the heart. Here, their temperatures are going to be above 1015. Splenomegaly. So we're going to do their blood cultures, anti-inflammatory. Antibiotics, they're going to be at least 2 to 8 weeks. So they'll probably be going home on antibiotics or coming in for outpatient antibiotics. We want to watch for decreased organ system perfusion. Their prognosis can be poor. You're dealing with that heart there. So we've got to try to get them when we can, as early as we can. What's some things that can cause this? Put that on there.
Drug use?
Right, drug use. You're going to see a lot of drug use that will cause this. Along with the drug use comes bad dental care. So the dental care, that causes infection, which goes to the heart. So there you go. But yeah, the drug use, it comes along with that. Okay. Pericarditis. So inflammation of the pericardium. Acute is less than 6 weeks. Usually viral and affects men more than women. Chronic causes a pericardium to become rigid. Both of these can be caused by infection, cancer, high-dose radiation exposure, autoimmune disease. Certain drugs can be idiopathic. They can have chest pain, heart palpitations, fever, malaise. Okay. Most common complication is a pericardial infusion. I think that's the next slide here. Okay, so this is our myocarditis. No, that's a pericarditis. This is still the picture of pericarditis. Sorry about that. And there's our pericardial tap, okay? So see how they take the needle straight into the heart. Now this is our myocarditis. This is inflammation of the middle layer of the heart. So this can cause the heart failure and arrhythmias. Factors that can alter the immune response, such as alcohol use, malnutrition, stress, advanced age. So we're going to treat it by medications, activity restriction. Depends on what's going on there. All right, so that's our cardiac disorder.